Hello, everybody, and welcome to part 2 of the Hughes-Clues trauma. So we have completed all the components of the primary survey, and we've addressed the life-threatening injuries, and so now it's time to begin the secondary survey. And the secondary survey is a brief systemic process to identify all the remaining injuries. So there are many different nursing interventions. I've tried to give you the majority of what the remaining tasks that need to be done. If you want to read more, then you could go to the textbook. So what we have is the remaining alphabets, which is F, G, H, and I. When we look at F, we see that full vital signs, focused adjuncts, and family are within the F. And then G is give comfort measures, that's give pain medicine. H is history, and we take a history using the AMPLE acronym, and then we want to inspect the posterior surfaces. In other words, we need to log roll the patient if the C-spine hasn't been cleared. Otherwise, once the C-spine is clear, then we would just turn them over. But either way, the posterior surfaces have to be assessed. So full vital signs are taken, and a CT scan of the face, neck, and abdomen are ordered. So administration of CT contrast is required, which means that the patient needs to have a nasogastric tube. And a Foley catheter is also ordered. We've given the patient pain medicine of midazolam or Versed and fentanyl for sedation and pain control. And then I've got a bunch of questions here. Why is the CT ordered? What's the difference between a CT of the abdomen and a FAST exam? And so let's look at each one of these many questions, and we'll take them one by one. So why is the CT ordered? Well, the steering wheel or the seat belt can cause solid organs and the blood vessels in the abdomen to crack. So solid organs such as the liver and the spleen or the kidney, if they're injured, they will bleed profusely. And the assessment findings that would kind of indicate if these items, if these organs were injured, would be a hard and distended abdomen because it's filled with blood, and or decreased or absent bowel sounds. And of course, the patient can also have signs and symptoms of hypovolemia. Now, hollow organs such as the stomach, small intestine, and colon, those rupture, and they will then spill their contents into the abdominal cavity, which will later cause peritonitis and can lead to sepsis. And then as you perform the assessment, you've got to do a very thorough abdominal assessment, which means palpate, assess for tenderness and firmness, and then look and see if the abdomen is markedly distended. So what is the difference between the CT and the FAST exam? So the FAST exam stands for Focused Abdominal Sonography, and it is used for trauma. So it's specific for trauma. It essentially takes the place of peritoneal lavage. That's not done anymore, at least in the level 1 trauma centers, because the FAST exam will very quickly determine the presence of blood in the peritoneal space. Unfortunately, it cannot rule out bleeding in the retroperitoneal space. That's where the kidneys and a portion of the pancreas live, so we need a CT. So the FAST exam would be done very quickly, and if there is evidence of bleeding, then that patient is going to have to go to the operating room. If the patient was stable and the abdomen was soft, then a CT of everything can be done, and you don't need the FAST exam. So the FAST exam is just like what it is. It's got to be done fast in case there is some copious bleeding from those cracking organs. So again, abdominal assessment is very important. Now, would you insert a nasogastric tube? No, you're going to insert an orogastric tube. So it's the same thing, it's just a different placement. The end of the tube still goes in the stomach, that's the gastric part, but we're going to put it in through the mouth and then into the stomach instead of the nose. And that is because any patient with any kind of facial injuries and or a suspected skull fracture, the tubes need to go in through the mouth. And so most trauma patients will have an orogastric tube. What assessments are needed prior to the insertion of the Foley? And then what assessments are done after the Foley is inserted? So we know that the bladder is typically hollow, and therefore hollow structures can crack, or not crack, but they can pop. And what happens when the bladder pops is urine will be spilled into the abdominal area, and you wouldn't want to insert a Foley catheter in there, at least not in the typical way. We usually will put a suprapubic catheter in. And if, for instance, you had problems with the ureter or the urethra, if those were damaged, then you might notice blood at the meatus. So these are things that you need to look at before the Foley catheter is inserted. And if blood is coming out externally at the meatus, then the Foley would likely be delayed. Now, if a Foley catheter is inserted, or even if it's another type of urinary catheter is inserted, we do want to collect the urine and assess for gross or microscopic hematuria, because we want to ensure that the structures as well as the kidney itself is not damaged. We would also assess the urine output, because the urine output volume tells us about the volume status of the patient. The minimum amount of urine output is 0.5 mils per kilogram, and then the range is 0.5 mils per kilogram to 1 mil per kilogram. Again, a very important assessment for the volume status of the patient. Now, when we're on to H, we're talking about the history, and you can get the history of the patient from a family member or from the patient themselves. And when you take a history, you're supposed to use the AMPLE technique, the AMPLE component. So A stands for allergy, M stands for medications, whether it's past medications, but also the need for tetanus prophylaxis. P stands for past health problems or pregnancy. I'm going to tell you that in real world, the urine is often taken and assessed for pregnancy before any x-rays are done. Last meal is also assessed in case surgical intervention is needed. And then E, events surrounding the injury. So we also want to provide emotional support for the family and provide them information as well as visitation rights. Now, the CT of the scan in our patient has been done, and they're all normal of the face, neck, and abdomen. And so no bony injuries and no solid abdominal organ injuries were detected. However, a right proximal tibial fracture is notified, and so the emergency physician will consult with an orthopedic surgeon. Now, because there is a tib-fib fracture, the patient is at risk for 3 additional problems, and that is a fat embolism syndrome, a DVT, and a compartment syndrome. So we're going to look at each one of these, identify what they are, and what interventions are needed for each one. So when we look first, we know that the individual is at risk for a fat embolism syndrome. So what is that? Well, whenever an individual has a fractured bone, and it's usually something like the tib-fib, femur, and or the pelvic. So these are fairly large bones. When those bones are fractured, fat globules can be released from the marrow of the injured bone. And these fat globules can enter the vascular space, and they will clog up. They can cause clogs as they travel to smaller vascular spaces. Now, the patient is at risk for a DVT, and this one's easy because anytime anybody has a fractured extremity, well, then you know that there is a problem with immobility. So what are the collaborative care for both of these things? And we're going to talk first about what is done for the fat embolism syndrome. So fat embolism syndrome, that's the leakage of fat from the bone marrow after a long bone fracture, can occur within 12 to 72 hours of the injury. And because it really does act just like a PE, you're going to see signs and symptoms of acute respiratory distress. And because there can be a poor oxygenation status, there can be altered mental status. Now, the one thing that is very specific to fat embolism is the signs and symptoms of petechiae around the neck, upper torso, conjunctiva, and mouth. I don't remember what the patho is of this. I just know that fat embolism, you can see these things. Otherwise, if you didn't see these petechiae, you might suspect that it's a PE, because it's really the same signs and symptoms, because the cause or the oxygenation problem is the same. So what is the treatment? Well, the treatment's aimed first at prevention. And we want to make sure that that fractured extremity is immobilized, because the more movement around will cause great pain to the patient, but it can also cause this fat embolism to come from the marrow. We also want to provide adequate IV hydration and likely prophylaxis of coagulation prophylaxis will be given too. And then, of course, DVT, this one you got. You want sequential compression devices, and obviously that's not going to be done on the fractured extremity, and then anticoagulation protocol. Now let's talk about another risk that this patient has, and that is compartment syndrome. You know that anytime an injury occurs to the bone, that, and especially with her case, because there is a fractured tibia, that there is trauma that results as, edema occurs as a result of the trauma. And edema will occur suddenly and then can worsen as the 24 hours progresses. And what happens is the edema that forms from the original injury takes up space, and that can cause pressure on the venous structures, so the venous blood vessel. And if there is enough compression on the venous blood vessels, then venous blood will not return, and you will have venous stasis. And when there is venous stasis, that is again going to kind of engorge the vessels, blood vessels in that space in the lower leg, and then you add the engorged blood vessels, plus you add edema, and now you even have more stuff taking up space, and that can then compromise the arterial blood vessels and the nerves. So it can put pressure and compromise arterial blood flow, and then it can compromise blood flow to the nerves. If arterial blood flow decreases, you know that the whole point of the artery is to deliver oxygen to the tissues, so you're going to have an ischemic state. If it progresses, then you can have an infarction or dead tissue, and then what can happen ultimately is that the extremity can be severely damaged, impaired, and in extreme cases can have to be amputated. So what is the manifestations and collaborative care with compartment syndrome? Well, anytime there is arterial vascular compromise, we assess the P's. And so the P's are paresthesia, pain, pallor, poikilothermia, and pulse. So we're adding some P's to the mix here, because probably one of the first things that will occur is the paresthesia, and that's the numbness and tingling. And then the individual will have pain at the level of the injury, but it will be suspicious pain. In other words, you might think, wow, this patient is telling me their pain is still very severe and they want more pain medicine when it's not time for pain medicine. Is this a drug addict, or is this a pain person? And so you have to be very cautious with that, because I know as nurses, we become suspicious of individuals who want a lot of pain medication. But, you know, there are times when the pain is true, and we're supposed to assume that it's true, and it could be a problem that is occurring, a complication. Then there's pressure and swelling. Again, you're going to see that right away. There can be pallor, which is paleness. Cap refill can diminish. And then poikilothermia, coolness of the extremity. Now, paralysis and pulselessness can occur, but those are very late and ominous signs. So don't miss out on the first 5 signs and symptoms. Be suspicious for any individual who has a long bone fracture. That would be tib, fib, femur, or hip. What are you going to do for these individuals? Well, you know that anytime there is any kind of bone fracture, you should elevate the extremity. And you elevate the extremity and apply ice above the level of the heart. But once there is a suspicion of compartment syndrome, that means that there is actual arterial compromise. That's when you go back and you reduce the elevation, because we don't want to elevate the extremity higher. We just want to kind of keep it obviously slightly elevated, which it would be if it's on a bed with the rest of the body. And we want to take the ice away. because ice will cause vasoconstriction, and then that will severely compromise arterial perfusion even more. So these are things that you do. So as soon as the injury is identified, you want to elevate and add your ice, and that is for the general edema. But once compartment syndrome is suspected, then that's when you change course and don't markedly elevate the extremities. Stop with the ice. Make sure there's nothing, a bandage or anything that's impairing circulation, and really, really assess your patient. I hope this has been helpful. If you have any questions, email me.